So good evening, and thanks to Dr. Mrinal and Dr. Venu, and for this opportunity. I'll be touching on the broad topics related to rehabilitation care and outcomes of traumatic brain injury, specifically focusing on moderate to severe brain injury. I have left it as an overview considering the vastness of the topic, and we have to go very fast because we have to move from coma to community. We should be very clear about the definition of TBI. TBI is defined as an alteration in brain function or other evidence of brain pathology caused by an external force. The terminology is traumatic brain injury. So I'll be touching on the broad topics related to the care and outcomes of traumatic brain injury, specifically focusing on moderate and severe brain injury. So I've left it as an overview. Considering the vastness of the topic, I think we have to go very fast because we have to go from coma to community. And we should be clear about the definition of TBI. It is defined as an alteration in brain function or other brain pathology that is caused by an external force. And the terminology is not head injury, but it is traumatic brain injury to indicate that it is damage to the brain and not damage to the skull or the scalp. And we can expand this definition further as shown here. I think you can read about it later. Now, traumatic brain injury is one of the most common of the serious disabling neurological disorders in India. At least 2 million brain injuries occur every year. Individuals younger than 30 are mostly involved, affecting important periods of their life, involving their educational development, vocational productivity, adult independence, beginning spousal relationships, and family development. And thirdly, TBI has a very extended natural history and lifelong effects. Thus, when you make a neuro rehab plan for TBI, we need to recognize the prolonged recovery timetable. And if we understand the natural history, it will help us to effectively apply the services at different stages of recovery and to avoid treatment that may not be necessary or which may be ineffective. Finally, TBI can have a wide variety of pathophysiological effects, a range of severities, and a multitude of problems, different courses of recovery, and the spectrum of outcomes can be very different. So there should be a breadth of services available for patients at different stages of recovery. So looking at the pathophysiological effects, you have TBI occurring in two phases. The primary brain injury, which is the damage that occurs directly as a result of the trauma. It can be focal or diffuse, or it can be a combination of these. I'm sure you know about all these. Contusions can be there: extradural hematoma, subdural hematoma, subarachnoid hemorrhage, intraventricular hemorrhage. And because of the rotational forces, you can get a diffuse axonal injury where there is shearing of axons and neuronal disconnection. Now, these contusions and intraparenchymal hematomas occur in the orbitofrontal and the anterior temporal lobes, and it can cause focal deficits and can increase the risk of seizures. Extradural hematoma is seen as a biconvex collection and is usually associated with a better outcome. Whereas in subdural hematoma, you have a poorer outcome because it indicates more severe brain injury, and subarachnoid hemorrhage can be seen as a high density fluid along the cerebral sulci. Following the primary damage, you get secondary brain injury, which, as you see in this figure, can be very complex. It includes different mechanisms like ischemia, then there can be excitotoxicity, secondary edema, inflammation, regeneration, all this leading to a raised intracranial pressure, and various other secondary physiological insults like hypoxia, hypotension, hypothermia, etc. can exacerbate these, and spontaneous cardiac arrest can result in hypoxic ischemic encephalopathy. And because of this elevation of intracranial pressure and edema, it can result in ischemia, and sometimes if severe, it can result in brain herniation and all the symptoms related to it. You know the term diaschisis, which is depression of functionally connected brain regions, that is areas in the brain distal to the lesion itself. There can be suppression of activity in those regions. Many neurotransmitter systems can be impaired. You know, the cholinergic pathways, that is important for memory, dopaminergic pathways, important for attention, and noradrenergic pathways, important for arousal, sleep-wake cycle, and vigilance. So what was the initial severity that the patient had? So it has been classified as mild, moderate, and severe. There is also a classification called a complicated mild brain injury with features of mild TBI and abnormal structural imaging. Usually in mild TBI, the imaging will be normal, and different factors can be used for this classification. So the assessment of the consciousness, the depth of consciousness with the Glasgow Coma Scale is an important part of the score, ranging from 3 to 15. I'm sure you know about it. For pediatric patients, there is a pediatric Glasgow Coma Scale, and another score is a full outline of unresponsiveness. Severity of injury is also measured by the duration of coma, the duration of post-traumatic amnesia, and the structural imaging. So understanding the clinical history, however, is more important for clinical care, because patients with mild TBI can later on develop a secondary brain injury and very severe impairments needing craniectomy. Also, there can be patients with severe brain injury having a very good recovery. So these initial classification categories may help to understand the clinical course, but may not predict the severity later. Functional recovery occurs through neuroplasticity. There are various mechanisms which can be augmented by intense practice and structured therapy, and most of the recovery occurs within the first 6 months. And even after 3 to 5 years, there can be functional improvements occurring with rehabilitation. Now, outcomes after TBI are very different in different patients. Physical and functional recovery often recover earlier than cognitive abilities, and because of the severe cognitive and behavioral issues, many of them are not able to return to their pre-morbid functioning. You have heard about the Glasgow outcome scale already. It is a global scale of disability after TBI. It includes monitoring of death as well as vegetative state, and then different levels of recovery. So you know that in vegetative state, patients are unable to interact with the self or environment. In severe disability, they can follow commands, but they are unable to live independently. They need assistance throughout the day. In moderate disability, they can live independently, but they are not able to return to higher levels of function like work or school. And in good recovery, they are not necessarily without any impairment, but they can return to all life activities, even though they may require some sort of accommodation. Now, another scale is disability rating scale, from tracking a patient from coma to community. You have heard about it. And there are other outcome scales in the functional independence measure, which measure progress in therapy, planning the duration of rehab. Then you have the Mayo Portland adaptability inventory, which is used after discharge. Then there are various scales to measure community integration as well as the quality of life after brain injury. Now, in traumatic brain injury rehabilitation, there is a clinical continuum of care from the emergency medical services, then the early intensive neurosurgical care, acute medical care, then the comprehensive rehab acute services, followed by community integration, where you need long-term services like psychosocial and vocational services. So rehabilitation is very important through all these stages, and the choice of service will be based on the stage of recovery of the patient, the need of the patient and the family, and the availability of the various resources. So in the ICU, patients are admitted for limiting secondary damage, for minimizing the intracranial pressure, and for enhancing neuroprotection. And surgical management is done when the adjacent structures are compressed and there is herniation. And there are very clear guidelines for surgical management. So right from the ICU, if the physiatrist is involved, it has been proven that the outcomes are much better, because multidisciplinary rehabilitation and neurostimulants and all can be started very early. Then the patient can be transferred to the acute rehab program, and they are medically stable if there are residual impairments which are severe and he remains dependent. In an ideal situation, they should be able to follow single commands. They should be able to participate in at least 3 hours of therapy to benefit maximum from this program. But if they are not able to tolerate this, they can be managed at home with supportive care, or in a nursing home management can be provided. And if they have recovered very well, they may continue rehab on an outpatient basis. The goals of rehabilitation at this stage will be to prognosticate, manage various complications, then reduce the impairments, improve their functional recovery, and then long-term follow-up. Now, prognostication is very important at this stage, because it will give some information on the expected outcome to the families, and it also help to develop individualized treatment plans. With some degree of certainty, you can tell the relatives that severe disability is unlikely when the time to follow commands is less than 2 weeks and the duration of PTA is less than 2 months. And also, good recovery, that is according to the GOS, is unlikely when time to follow commands is longer than 1 month, the duration of post-traumatic amnesia is greater than 3 months, age is more than 65 years, and early MRI indicates bilateral brainstem injury. So, but there are various other psychosocial factors like financial resources, the availability of family members to care. Also, we have looked only at the brain injury. Somebody would have had a good cognitive recovery, but because of polytrauma or musculoskeletal complications, the ability to care for themselves, to walk and live independently may be limited. So, understanding the individual patient is very important. There have been various models developed to prognosticate, like the impact model, the crash model, etc. Now, various medical complications may be present during this acute rehabilitation period. Very often, feedback from our team members help to identify some of these. So, about 60% patients, like Dr. Sanjay Pandey said, many patients develop pneumonia, and several patients come with tracheostomy. Tracheostomy itself will have complications like granulations and tracheal stenosis, And the question will be when to decannulate. So ideally, if they're able to tolerate at least 24 hours of corking, they're adequately conscious, there is no aspiration, no infection, they have got an effective cough, they can speak clear long sentences and have got normal or near normal swallowing, then decannulation can be safely done. Otherwise, after the rehab process is over, they can be sent home, teaching them how to suction, how to do tracheostomy care, and then they can follow up with ENT to coordinate the further management. Nutrition, as emphasized again and again, is very important. There can be an increased protein breakdown following TBI. And loss of 10% body weight may not be significant, but the calorie needs are increased during therapy. So you may have to add on supplements, serum albumin, weekly weight measurements may be needed. Swallowing, get high risk of aspiration. Many of them come with an nasogastric tube. So the goal will be to achieve safe swallowing and maintain adequate nutrition. So bedside swallowing, NPL scopy to look for aspiration or penetration. Then with the help of a speech therapist, graded return of oral feeds. And tube feeds may be discontinued once they are able to take all feeds of all consistencies in adequate amounts. Sometimes the fluids may have to be thickened, postural changes may have to be advised. If swallowing does not progress, PEG may have to be considered. Now, thromboembolic disease, the incidence is about 20% during the time of rehabilitation. Here, there are safety concerns because of the intracranial bleeds, because of the impulsivity, the risk of fall, etc. So, if it is prophylaxis, anticoagulation will be discontinued as soon as the patient is ambulant. And if there is a thrombosis and if there is an intracranial bleed, anticoagulation may be contraindicated. This decision has to be taken along with the rest of the treating team, like the neurologist and the neurosurgeon. And in that case, inferior vena cava filters may have to be considered. Autonomic issues, I think you'll already heard about this. The episodic uncontrolled surges of motor and sympathetic activity. It's called paroxysmal autonomic instability with dystonia. We have to identify the trigger and treat with medications like beta blockers or long-acting benzodiazepines. Seizures, the incidence is about 17% in non-penetrating injury and about 65% in penetrating injury. It can be an immediate seizure which occurs within 24 hours, early seizure occurring within 1 week, and a late seizure which occurs after 1 week. The onset of the first seizure can be as late as 5 years. So if you are giving prophylaxis for a late post-traumatic seizure, it may be indicated only in a high-risk patient, considering the cognitive side effects of anti-epileptic medications. So once there is a late seizure, the goal is to control with one medication. And once the seizures are controlled, try and substitute with an alternative anti-epileptic drug to minimize the cognitive side effects of drugs like phenytoin. And the anti-epileptic drugs may have to be continued for up to 2-year seizure-free period. Because of the location of the pituitary in the sella turcica, post-traumatic hypopituitarism can occur in many patients. Acute phase, there are several transient changes, especially gonadotrophin deficiency, etc. And later on, new deficiencies occur, and the long term, about 25% patients can have one or more pituitary hormone deficiencies. So serial pituitary function assessment is recommended in those who are at increased risk of developing endocrine complications for at least up to 1 year. So because this can cause growth hormone deficiencies, especially in children, menstrual cycles can be impaired, chronic hypothyroidism can lead on to cognitive decline. There can be diabetes insipidus because of vasopressin deficiency. And you all know about SIADH because of excessive ADH secretion, and hypogenatremia, cerebral salt wasting is the DD here. And whenever there is a decline in sensorium, think of hydrocephalus, shunting may have to be done. But then there can be a problem called syndrome of Trephind or sunken flap syndrome, because the forces of atmospheric pressure and gravity overwhelm the intracranial pressures, brain appears sunken, and these symptoms can be reversed by cranioplasty. Otherwise, cranioplasty can be delayed for 6 months or longer. Spasticity, you'll have a session on all this, but in brain injury, antispastic medications have to be used with more caution because of the sedation and the cognitive side effects. But in a patient who is in a lower responsive state, you may use high doses of antispastic medications, but you can periodically taper and look for the sensorium. And incidence of contractures is about 84% in severe TBI. Surgical correction is indicated only in chronic patients and rarely considered in the low awareness states. Fractures, many patients have concomitant fractures. Many of them may be undetected initially. Usually early fixation of fractures is suggested in case of traumatic brain injury. HO is another complication. Hips, elbows, shoulders, knees may be affected. The treatment of HO. Surgical excision is done if functionally indicated, if there is any functional goal to be achieved after the HO is mature. Now, these impairments and functional limitations, all of this have to be evaluated comprehensively by the whole team using a range of measures. You heard about various outcome measures, and it gives information on the patient's consciousness, the physical impairments, the cognitive behavioral issues, the psychological issues, communication problems, functional limitations, background of the patient, including education, vocation, family support, architectural barriers, etc. So also you need to understand the stage of cognitive recovery. Patient goes through different stages of cognitive recovery, and that is standardized using the Rankos, Los Amigos stages of cognitive recovery. Broadly, this is the vegetative state and the minimally conscious state, that is the low awareness state, followed by the confusional state, and then the post-confusional state, and the social stage of social competence and community re-entry. So and you make a comprehensive function-oriented rehab goal. And after these assessments, the goal will be to progress the patient from the low awareness state through the post-traumatic amnesia, the agitation phase, to achieve functional independence and community re-entry. Actually, there are no preset formulas. Each patient, the goal has to be tailored to the patient's needs, and the involvement of the family and the whole team is very important in this process. So in the initial stage, arousal is the main problem because of damage to the reticular structures. In early stage 2, that is the unconsciousness wakefulness syndrome, sleep-wake cycles are present without awareness. In early 3, there are some inconsistent response to commands, and you should look for the changes very objectively using various serial neurological observations, evoked potentials, etc. Because if you do not recognize these changes, you may attribute a false poor prognosis. You have heard about the coma recovery scale to differentiate the vegetative and the minimally conscious states. And also the Wessex head injury matrix is another scale to look for these behavioral changes. It was created by observing the behaviors. And during the stage, our goal will be sensory and proprioceptive stimulation, optimize the medications, achieve sitting and verticality, again prognosticate, evaluation of airway, managing medical complications, and looking at nutrition. So, and multimodal stimulation is given with various stimuli, and the stimuli all have to be contextual depending on the interest of the patient, rule out treatable causes, look for responses like focusing, are they tracking, are they localizing, are they able to differentiate, are they able to obey commands, and is this very consistent? And you have to stop all the sedative medications, rule out all the treatable causes, and some neurostimulants like modafinil or levodopa, amantadine, etc. can be tried. Goal is to create an environment that facilitates maximum emergence from coma and prevention of complications. Right median nerve stimulation has been shown to be effective by activation of the ascending reticular activating system to improve the consciousness. Hyperbaric oxygen therapy have been tried. Sitting balance has to be improved. And about 10% of the patients who open the eyes may fail to recognize consciousness, and they remain in the vegetative state because there are several factors that can prognosticate regaining consciousness. Recovery from the vegetative state is unlikely if it is more than 1 year. Now, next, the patient moves to the agitated stage, that is early stage 4, where there can be severe basic attentional deficits. They are not able to concentrate, and they have difficulty following directions. They're not even able to recognize their family members. Then post-traumatic amnesia, agitation, sleep-wake cycle disturbances are the characteristic features of this stage. And in post-traumatic amnesia, patient is unable to retain any new information, and this can last up to a few months. And this is classically tested using the Galveston orientation amnesia testing. You might have heard of shrinking post-traumatic amnesia, which is a reduction in the severity and the temporal extent of the amnesia, retrograde and the post-antegrade amnesia. Now, during this time, orient them to people, place, where they are going, what they're doing, structure the environment, then you orient them to time. And the main challenging problem during this stage is agitation, because it can cause a lot of stress to the families. It is a safety concern for patients, caregivers, everybody involved, and it interferes with the therapy. So they may remove their lines, they may pull out their tubes, they may wander or pace around. So if the patient is agitated, you may have to look at other causes. Is it due to pain or sleep deprivation, or is it a post-traumatic delirium due to infection or electrolyte and metabolic disturbances? All these have to be ruled out. Then this is a measure of post-traumatic agitation, agitated behavior scale. And during this period, you can make a chart looking at the antecedents, behavior, and consequence, and try to avoid the antecedents, make a behavior modification plan. And the first line of management is to reduce the stimuli by minimizing all the unexpected situations, remove all the external distractions. Safety is important, so floor nursing, padded beds. So all this will be useful. Seat belt should be given whenever they are on a wheelchair. All the tubes are removed as soon as possible. And instead of physically restraining, soft hand bits can be used if the patient tries to pull out the tubes. Agitation usually clears in 2 to 3 weeks. But if it doesn't clear, there is persistent agitation, Pharmacotherapy may be used, usually beta blockers or antipsychotics. You may have to look at the ECG and QTC interval when you are increasing the dose. And you may have to give medications to improve the sleep also. The general principle of starting all these medications is start low, go slow, but go and stop as soon as possible, because the injured brain is sensitive to the side effects of drug. So the ultimate aim is to substitute all these medications with non-pharmacological interventions. And if you have drugs that will be helpful for more than one indication, you can go for those drugs. Now, some therapy, some learning through repetition is possible. Even during this stage, improvement in ADL, mobility can be done. You limit the number of people who are interacting. Everybody should respond appropriately, consistently with simple short sentences introducing themselves. Break down the task into smaller steps. Give simple step-by-step directions. So then after some time, as the cognitive stage improves, patients are no longer agitated, but they are very confused, distractible. Memory will be very poor. They may try to fill up the gaps in their memory by making things up. That is called confabulation. They may get stuck on an idea or an activity. That is called perseveration. And as they improve, they get better. That memory gets better. They can follow a set schedule, and some activity can be given. And again, during the post-confusional state, memory is better, but they have problems with executive functioning, multitasking, or problem solving. They have no awareness of the deficit, so they have safety issues. They need supervision. And as they improve, they realize they have problems. They begin compensatory methods. They need assistance only when they are in new situations or making new decisions. So several cognitive deficits, you'll have a lecture on this tomorrow, but attention, problems with memory, visuospatial functions, hemi-neglects, then slowness of information processing, spatial and social cognition, all this can be affected. Especially important is executive function deficit. It's the most difficult problem, difficulty in problem solving, prioritizing, multitasking, etc. So you have heard about this Edinburgh's cognitive testing, Montreal cognitive assessment. In patients with aphasia, cognitive linguistic quick test is a test that can be used. So pharmacotherapy is not often used, but you can try drugs like bromocriptine and amantadine or donepezil and rivastigmine, etc. But cognitive rehabilitation has been found to be very effective, and for mild cognitive issues, you can use a process-specific training where you teach the cognitive skill that is impaired again and again, using different paper, desktop tasks or computerized tasks. Whereas in moderate and severe cognitive issues, you can use a compensatory strategies using various internal or external strategies like a memory book or a phone or a pager, etc., to improve the domain. And in skill-specific training, the functional activity is repeatedly practiced in an errorless manner, breaking the task into simpler steps. So, but among all these different sequelae, neuropsychiatric issues like aggression, apathy, disinhibited behaviors, pathological laughing, crying, etc. Those depression is very common. About 56% may be because of the common neurotransmitters that are involved in depression and TBI. Mania, psychosis, etc. are little rare, but these have the highest impact on the rehabilitation outcome and the most distressing for the family. And you have to look at whether it's pain causing this, or lack of sleep, loss of job, or cognitive decline causing these neuropsychiatric issues. And there are scales again like neuropsychiatric inventory, which can help to get an overall picture of the neuropsychiatric issues. Various behavior modification strategies can be introduced. Sometimes pharmacological interventions may be necessary as a first line, depending on the symptoms. Again, start slow, go slow, and should be increased slower than the patients without brain injury. And a second drug with a different mechanism of action can be added if there is only a partial response to the drug. Various drugs can be used depending on what is the problem. And again, vision problems. This is often ignored or misdiagnosed, and it can impact on the progress in TBI rehabilitation due to injury to different parts along the visual pathway. There can be field deficits, oculomotor deficits, diplopia, or hemi-neglect, lesions like prosopagnosia, which is the difficulty to recognize faces, simultagnosia, etc. So it can create difficulties with activities of daily living, mobility, or climbing stairs, headache, etc. So detailed neuro-ophthalmological examination will help, including field assessments, tonometry, etc. And many of them can be managed with simple measures like contact lenses or prisms for neglect, or patching for diplopia, or asking the patient to consciously scan into the area. The help of a neuro-ophthalmologist, all these can be done. Some patients will have vestibular issues, especially if there are visual and somatosensory problems. It can cause balance issues, and you can give vestibular balance rehabilitation therapy or some vestibular suppressants. Sometimes patients may have sensorineural hearing loss, and hearing aids may be helpful. Movement disorders, again, tremors, dystonia, myoclonus, post-traumatic Parkinson's, and all add on to the disability of the patient, can manage with various drugs, and prevention of disability and contractures, all this should be the goal of our rehabilitation. Sleep disturbances, very common, the prevalence of 68%. In acute injury, it is disorder of initiating and maintaining sleep, whereas in chronic injury, it is a disorder of excessive somnolence. And they sleep off in therapy, they've got fatigue, difficulty concentrating, etc. And you can test it with actigraphy, polysomnography, etc., which is not commonly done, but you can maintain a sleep-wake diary, establish a good sleeping pattern, you can reschedule the timetable so that the cognitively demanding task can be scheduled when the patient is maximally alert. Sometimes medications can be given to improve sleep, like trazodone or melatonin, solpidem, antidepressants, etc. And sometimes if they have got excessive daytime sleepiness, not due to other causes, you can give a wake-promoting agent like modafinil. Pain is very common during this rehabilitation phase, and it can affect progress, it can affect their sleep, cause agitation, they can avoid activities leading to various limitations. So avoid the pain from becoming chronic, and analgesics can be given before therapy because it can provide better pain relief. So because of all these issues, physical rehabilitation is very complex. And along with that, you have alterations in tone, voluntary control, there is balance issues, apraxia, then musculoskeletal issues like contractures, deconditioning, heterotopic ossification, etc. So you need strategies to improve the normal movements as well as the cognitive processes that are required for the motor learning. The goal will be to progress the patient from the way through the various stages of cognitive function recovery, RLA staging. In the stages of low arousal, they can be made upright in a wheelchair. And then as the trunk control and balance improves, you progress them through walking in parallel bars, proceed to walking with walking aids, initially on a level ground. Various innovative neuro rehab tools, as already discussed, based on motor learning principles to stimulate the neuroplastic processes like the treadmill, body weight supported treadmill training, robot assisted training, virtual reality training, which provides a comfortable and motivating environment. Again, patients are unable to do their ADL basic activities. You have to assess their home environment, the cultural context, to develop strategies to overcome the various architectural barriers. There may be safety issues, problems with impulsivity, inappropriate behavior. So frequent breaks may be needed, and the entire team, including the nursing staff and the family, have to be involved in training the ADL, because whatever activities are trained in therapy have to be carried over to the room and later on in their home. So encourage independence in ADL. Maybe aids may be needed. Again, as already mentioned, CIMT, mirror therapy, etc., can be used for hand functions. Instrumental activities of daily living, that is, the aids to independent functioning, such as meal preparation. Community outings will be helpful to assess and treat in real life situations. And practice should be given in as many contexts as possible so that all the skills learned can be generalized. And other technologies include hand tutor, virtual reality, biofeedback, and also robotic devices to improve hand functions and the shoulder and elbow movements, etc. Now, speech and language issues, dysarthria is the most common speech disorder. Exercises are given to improve their vocal loudness and intelligibility. Communication problems secondary to cognitive dysfunction are called cognitive communication disorders. FAC is not very common in brain injury. So you can give speech therapy, rehabilitation of language deficits using restorative, compensatory, and behavioral techniques. Gesture therapy and augmentative communication aids can be used in case of aphasia. And as the patient moves to the next stage, they're able to do multitasking, social skills are improving, they're able to do household duties, they're ready for community re-entry, for work or education. And you can do a more detailed neuropsychological evaluation with various tests during this phase to understand if they're ready to return to work or school. So these are some of the neuropsychological tests, but the structured assessments may not always predict how they will manage the complexities of everyday life. So instead, you can challenge them in challenging situations. For example, is a multiple errands test to evaluate the effects of executive function deficits. Return to work is very important because they are all very young and their whole working lives are ahead of them. And moreover, return to work improves the quality of life and community integration. Counseling and training will be important. The occupational therapist and the social worker can be involved with this to provide suitable employments and assessments, and coordination with employers can help to develop an accommodative work schedule and a very supportive environment. Can work with the local schools and colleges, designing school and re-entry programs. Many patients come with the question whether they can return to driving. So in addition to motor skills and the physical skills, they also, and the good vision, they also need to good way, lot of cognitive skills like problem solving and the information processing time, reaction time, etc. And they need to be free of seizures for a particular time period. Sedative medications such as antiepileptics and antispasmodics need to be considered. So you can check their ability on driving simulators prior to on-road driving. And some patients may be given retrain. So many patients go through a lot of emotional stress, families. So brain injury support groups may be helpful to get them enough information to give them emotional support. And network among patients, they can learn from other patients. Leisure needs also needs to be considered. So there are various other groups of patients, like children with brain injury, older adults, patients with mild brain injury, caregivers, they've all got special problems and special attention needs to be given to them. Follow-up is very important, ongoing involvement, even after discharge, through OPD visits or telephonic follow-up or home visits. Readmission may be needed if there are infections, psychiatric issues, orthopedic surgery, seizures, hydrocephalus, or if they have got functional improvement to further improve that. So CT scan can be done if there is a neurological decline, the risk of Parkinsonism, the risk of stroke can be increased. So thus the brain injury impacts all the facets of an individual's life, changes the course of what they were going to be, changes their vocation, disrupts family and social relationships. They become dependent on their family. They will have increased mental health needs. They can have chronic depression, anxiety, etc. So each TBI differs from person to person. The range of supports will vary. The range of services and the needs will vary. So role of family cannot be emphasized even more and more. So the aim is to improve the patient's final functioning and quality of life. So you have to match the right patient with the right training, with appropriate rehabilitation strategies at the appropriate time. Thank you.